Good morning and welcome to the Breakfast with the Chiefs. For those of you who I've not had an opportunity to meet before, I am Matthew Hart, CEO of Longwoods Publishing. Please feel free to introduce yourself. Before we start, every Breakfast with the Chiefs is supported by organizations, and without those organizations, we would not be able to put on these events. So supporting this morning is the Canadian Foundation for Healthcare Improvement, Life Labs, I believe Roy Sod and Mario Longo are here. Mario is in the back, get an opportunity. HEROC, is Philip here this morning? Nope. Oh, sorry. Yeah, so HEROC is here this morning. NRC Health is supporting this morning. Servesh, are you here? Ron, are you here? Oh, Ron's over there. And then KPMG and Julia Wong. Did she make it this morning? Nope. Also with great thanks to Rotman for this facility. For those of you who have not had an opportunity to meet Brian Golden, he is here to introduce the speakers this morning. I'm sure he would love an opportunity to speak with you, so if you do get an opportunity, say hello to him. Without further delay, Brian.
Good morning, everyone, to the Rotman School. I think I've seen virtually all of your faces here multiple times, so I'm really pleased to see you here again. So I have the distinct pleasure of introducing two people who don't need an introduction at all. So since I've got an extra 15 seconds, I will just welcome you to our school and let you know that the school is the home of a suite of healthcare and life sciences programs from all the way from our full-time MBA to our newly launched executive MBA, the Global Executive MBA in Healthcare and Life Sciences, which will launch next October. So if you've been here before, you've heard me say that, so I spend a few seconds less each time. So I'm going to move away from that now, and if you have any interest in learning more about the program for yourself or for others, please see folks in the back. Proper introductions. We are fortunate to have to be in conversation today with two great health system leaders in Canada. A recent health system leader in Canada, Dr. Mike Apkon. Mike is the physician executive in pediatric specialist serving in senior leadership roles at top academic hospitals in North America. He has served as the CEO of SickKids since January 2014, and prior to coming to SickKids, Dr. Apkon held roles as the Chief Medical Officer for the Children's Hospital of Philadelphia, or CHOP, and as the Executive Director leading the Yale New Haven Children's Hospital. He's currently a Professor of Pediatrics at the University of Toronto and has held faculty positions at UPenn, Yale, the Yale School of Medicine, and the Yale School of Management. Now, he's also an MBA, not a Rotman MBA, but Mike has a BS in biomedical engineering from Northwestern, pleased to say, and is an expert specialist and huge advocate of quality and patient safety. You'll obviously be in conversation with him shortly, so I always enjoy my time, the few moments I have with Mike in conversation, but today is not my day, it's Ross Baker's day. So Ross, I think everyone in this room knows, is the professor and program lead of the IHPME. I'm even jointly appointed there, I should remember that, IHPME Masters of Science degree with a concentration in quality and improvement in patient safety. So always a lot of letters, always a lot of words, but a lot of impact in all of those programs. He's the co-lead for the Improving and Driving Excellence Across Sectors Ideas programs that's funded by the Ministry of Health. If you've been around Ontario long enough, you know Ross was the founder of the Hospital Report Card, was one of the co-leaders of a critically important patient safety report in 2004, which has changed the way we think about safety and measurement in Ontario and in Canada. And we're fortunate that we are in conversation with Ross and Mike this morning. So please welcome both Mike and Ross Baker.
Good morning, everyone. Thank you, Brian. It's great to see so many colleagues and SickKids staff and friends in the audience. 4 years ago, I had the professional opportunity of a lifetime. I had an opportunity to join an iconic organization that has been a field shaper in my field in pediatrics since I was a medical student, and names luminaries in the field that I learned about through my entire medical education. It offered an opportunity to join the organization at a time when it was about to open a research facility that was the envy of the entire pediatric healthcare world, and in fact, one of the most advanced facilities anywhere in healthcare. And it was a time when the board was interested in building on a very stable foundation, a really incredible history, but was really interested in exploring new ways to ensure success in a rapidly changing environment. And there was a sense that the healthcare system in Ontario at the time was focused on transformation. It was a year or so after health system funding reform, and a lot of indication that there were going to be further changes in the way the system evolved. And they were really interested in transforming funding, the structure of healthcare, the approach to service delivery, the use of technology, a lot of things that I had spent my career sort of building to think more and more about and in a broader and broader way. And so I took on that opportunity, and truth be told, I knew very little about Canadian healthcare. I had studied in business school one course in cross-national learning in healthcare and healthcare economics, and about all I really knew was that there was universal coverage, which was a concept that resonated really well to me, coming from a country and a system where there were more people uninsured at the time than there were citizens in Canada. And I faced, as a chief medical officer, the very real experience of having to deny families coverage, even though they lived in the same block as the hospital, because they didn't have the right insurance coverage. So the challenge in coming in was thinking about a multi-year strategy in an environment I wasn't that familiar with that would address not only today's healthcare needs, but assure that we preserved our impact and our stature as an organization at SickKids long into the future, and to be able to do that without really knowing fully what the environment was going to evolve to. And so you develop a strategy that's going to take you out 5 years, 10 years. You don't really know what the health system is going to look like at that point in time, or what the system is going to need for you. All you know is that you want to continue to be viewed as highly successful, field-shaping, in an iconic institution. I also knew that whatever we came up with as an organization, it was going to have to make sense to people in the organization, to the board of trustees that we're going to have to approve, and the public that supports us through philanthropy, as well as to key partners around the system that we're going to have to be willing to think about a different relationship with us, possibly, or a different role for us. And the fact is that CEOs, boards, and executive teams might develop and describe strategies, hopefully with a lot of inclusive process, and that strategy might be thought about as a roadmap around what they have to look like or act like into the future. But the reality is that they're not the ones that actually follow that roadmap, and they don't actually create the success. It's in our organization 10,000 staff, trainees, volunteers that have to align their energy in a way that propels us along that strategic roadmap if we have any prayer of it becoming our reality. So I guess the way I've kind of come to see the role of the leadership team and the CEO in particular is really to develop strategies by making sense of what's happening and predicted to happen in the environment, and turning that into a roadmap, and then helping people make sense of that roadmap and the external and internal pressures, as well as what they need to do for us to be successful. And the engineer in me, engineering education is all around trying to understand models of the way different systems work, and kind of thinking about building different models to have different outcomes. And the way I've kind of come to see models is that all models are flawed in one way, shape, or form. Some models are useful. And I think the one way to make sense of the world is to try to turn it into models that you can use to describe the way the world works and the way you need to kind of perturb systems to get the desired outcome. And so what I thought I would do is, before I sit down with Ross, is to share the mental model that I've developed in thinking about healthcare, and to relate that to the strategy that we've adopted at SickKids. And I will say that almost every conversation in some way, shape, or form refines that model more and more as you sort of test whether it works or not, by the things, the conversations you have, the things you try to do, the ways you try to get other people to see things. And the mental model I want to share with you is built around the concepts of versions in healthcare. And you think about the Windows operating system and DOS 1.0, 2.0, Windows 95, and so on and so forth. So I'm going to walk through the way I've seen healthcare and see healthcare evolving over sort of 4 major transformations. And I'd say that there's 3 major factors that I see driving that evolution. And they're factors that actually are not that different in other industries. And one factor that maybe is a little bit more unique to healthcare is specialization. So specialization is a way to manage the technical and cognitive overload that happens as we develop more and more capability and more knowledge. So if you think about the field of pediatrics, it started out where you had pediatric generalists that sort of took care of the kids from across all systems. Then we started subdividing into the ologies: cardiology, endocrinology, gastroenterology. Then cardiology became more specialized, and we had interventionalists and non-interventionalists. Now, on the non-interventional side, we've got heart failure experts, intensive care experts, and imaging experts. With each subdivision, you're taking care of a narrower and narrower problem, which has to, in order to keep busy, reach a bigger and bigger general population to have enough people that need that specialized service. And so that's one factor. A second factor is the need for scale. Scale to generate economies as we try to find efficiencies in our industry, and also scale that allows us to progress in new evolving areas. And the best example I can think of is the concept of precision medicine. In order to tailor a therapy to an individual based on their genetic composition, we have to understand that individual's genetic composition across the backdrop of a very large population. And the less frequent a variation in somebody's genome, the bigger the population you need to study in order to be able to make sense of that individual and to tailor that therapy. You can only get there by having scale that actually covers a big population. The third factor, and this is one that I think is true across all industries, is the inexorable march towards greater value. And I can't think of any industry that has survived by preserving or decreasing value. I think you look at aviation or retail or financial services, those industries have all evolved and the systems have evolved to deliver greater and greater value for the customers. And it could be about generating more margin by attracting more customers and a greater willingness to pay. It could be about mission, trying to have a bigger impact in our not-for-profit organization. Or it could be about simply staying in power if you're government, thinking about how do we create more value in the systems that we're publicly administering. So now let me walk you through the sort of 4 healthcare reversions, and I'll start with before what I'd call modern healthcare, and that's the sort of what I'd call pre-healthcare, which happened when we didn't really have very much we knew how to do. There weren't many useful medications. It wasn't particularly safe to do surgery because you couldn't do anesthesia and prevent infections, and that's sort of like before the early 1900s. And there, the whole healthcare system, if there was a system, was really built around individuals with the charisma to get people to believe that they could do something useful. And there were, the heroes of the day were actually the Florence Nightingales that weren't focused on delivering medications and surgeries, but were really focused on compassion, caring, paying attention to the things that prevented people from getting worse when they were infirm or ill. Hospitals were really built around the nurses. I think about SickKids 146 years ago. It was really built around the nursing care that was delivered to help kids stay well-nourished and clean and safe while they were sick. And there really wasn't much of a need for a system. So that really started changing when we began to have the invention of reasonable treatments and reasonable surgeries. And so you think about the sort of mid to late 1900s, or really the middle 2 quarters of the 1900s or thereabouts. And there we started having more effective medications and greater surgical capability. And the system was organized around the people capable of making episodes of care effective. So making a diagnosis and prescribing a treatment, doing a surgery and treating some illness. And the heroes of the day, truth be told, not that nursing was diminished at all in importance, it continued to be very important, but we really saw the elevation and importance of physicians, and in particular, the sort of the master clinician, craftsman physicians that could do things that other people couldn't do, and could do it at a very high level. And if you think about what happened then, you saw the organization of healthcare. Hospitals played a very important role because they were places that provided the tools and the environment for physicians to do that work. But if you think about the governance within the hospitals, it was really built around the organized medical staff. And that's really the time that the Public Hospital Acts were all being written around North America and prescribing the autonomy and the independence of medical staffs, and really using the medical staffs to drive the evolution of care within the hospitals. Care was very local. If I think about my own field in pediatrics and pediatric critical care, I'll talk about the way we think about pediatric heart surgery as one example. So in that healthcare, what I'd call 1.0, the first version of modern healthcare, we could suddenly treat congenital heart disease. And the treatment was, the first treatment was something called the Blalock-Taussig shunt. It was rerouting an artery to provide oxygenated blood to the brain. And the whole program was built around the skills of a few surgeons that had the ability in their hands to change the life of a child. And they held enormous sway, and hospitals tolerated a high degree of hierarchy between physicians and non-physicians. Over time, and so the care was still very local and very focused on the episode, the surgery. Over time, those episodes became more and more complex as we developed greater and greater capability, but which required more and more specialized talents. And so now we started to see governance and organization and sort of management of the system shift to hospital administrations, professional hospital administrations, because you needed to be able to convene all of the different specialties, both physician and non-physician specialties, and all the different pieces of equipment that needed to come together over a complex episode of care. And so if I think about pediatric cardiology, again, as an example, there all of a sudden we had treatments that we could offer for really complex forms of heart disease. The most complex form, something called hypoplastic left heart syndrome, where babies are born essentially with one side of their heart. But the treatment of that requires a really complicated surgery, a lot of intensive care, a whole bunch of different specialists, imaging, interventional cardiology, a whole gamut of specialties. And that episode goes on often for 6 months of a baby's life, and it requires a very different way of thinking about the management of that experience for a good outcome. What we're seeing now, I think, is what I would call healthcare 3.0, where we're trying to move away from episodes of care to thinking about healthcare delivery as a continuous but still system-driven process. So now, instead of us wanting to have that child with hypoplastic left heart syndrome survive to be able to be discharged home from that episode of care, now what we're concerned about is getting them into University of Toronto, Queen's College, and having them develop into well-adjusted, productive, healthy adults. That's a very different issue that requires now stringing care together across many venues, across time, across specialty, and paying attention to many different facets of their health care. And what we're seeing, if we look around the world, is the provision of care getting organized into what I'd call networks or value networks that are really creating a much greater continuum. And one of the big challenges there is, if I go back to this notion of specialization, which allows this great stuff to happen, specialization also creates a great deal of fragmentation. It tends to be become very concentrated and have to address the needs of a broad population, but most of the care that a child will receive over their childhood is not going to be in the hospital where those specialized services exist. It's no different in the adult healthcare world. I'm using pediatric experiences, but it's no different if you're an adult with heart disease or diabetes or chronic obstructive pulmonary disease or cancer. Same issues, same dynamics apply. And so now we're starting to really look at governance at a regional level or at a network level, and that's a different story. If I think about the future, so I'd say a lot of a lot of the developed world right now is stuck somewhere between what I'd call Hospital 2.0, still focused on episodes, and Hospital 3.0, healthcare as a continuous system-driven process. Where I think we're trying to get to is what I'd call healthcare 4.0, which is healthcare delivery as a patient-driven continuous activity. And you think about the experience now with commercial travel as an example. We've moved from the stagecoach, which was probably the equivalent of the healthcare 1.0 experience, to now needing really complicated systems to fly airplanes across the country, to now having very consumer-directed procurement of commercial transportation services through Expedia and Travelocity and things where people are now knitting together all the components of their travel experience and doing it in a very self-directed way. And in that version, the system is truly organized around the individual. There's really no tolerance for the hierarchy between organizations. Organizations provide more or less commodity services. But if you think about the coordination of services now across a continuum, you require a much different set of systems that where the governance begins to become necessary at a more societal or industry-wide level through standards, through regulations that make it possible for people to come in and facilitate the navigation of people, patients, families, information across a very distributed network in a way that can be very self-directed. And if I kind of think of what that means, for example, in the children's heart surgery, it would be a family knowing that they have a child with a diagnosis that needs to be addressed and being able to seek out the very best provider for each of the different components, regardless of what network those providers belong to, and to be able to assemble that team in a fairly seamless way and move information between them in a way that also is seamless. So with each of those evolutions, and I think you can see the same pattern in virtually every other industry, with each evolution, the importance of the prior pieces that made for a really good system don't go away. They continue to be necessary, but they're no longer sufficient. They have to either take on a bigger mandate or something will fill the void to try to add value around them. And so you need to continue being really good at what's necessary in the prior generation. In some cases, and maybe the most successful cases that I can see in healthcare, what's happened is the successful organizations have taken on a broader mandate. And I look at organizations like Cleveland Clinic that started out as a single institution clinic and now spans the world. In each of these evolutions, you still need really effective systems for quality improvement and for managing quality and safety at the sharp end, but you also need much greater sophistication in the systems to coordinate the movement of people and information and materials across a much more distributed network. So this way of thinking has had us really think at SickKids in very different ways. And our current 5-year strategy we're in the middle of, called Building Connections and Accelerating Impact, is really built around this model, although truth be told, the model has sort of evolved as we've gone. But first, we have seen it really important to have the best craftsmen in-house. And we go a long way to recruiting the best talent in every discipline: nursing, medicine, surgery, administration. And we know that we need that to continue to deliver value in the way we have. The second is that we've made really significant investments in promoting greater teamwork and coordination within the hospital. As an example of that, our Caring Safely initiative, which we're now about 2.5 years into, has had the ambitious goal of reducing preventable harm by 2/3 over 3 years. We've actually reached that goal. The focus has been by promoting better teamwork and coordination of services. We also have actively sought out partners to collaborate in forming a more formal network where membership rules, standards, and shared governance help elevate collaboration to the level that's necessary to survive in a healthcare 3.0 world. And last February, I think it was February, we formally announced the creation of a Kids Health Alliance with Holland Bloorview Kids Rehabilitation Hospital and the Children's Hospital in Eastern Ontario and Ottawa. And that's a way for us to do business with each other more effectively, but also to create a connection point for other providers further away across the healthcare system. And fourth, we're really looking to learn from other industries and to partner with non-traditional healthcare partners as we think about how to facilitate a more patient-driven approach. So last night I was with a group of tech tech innovators in Toronto that have committed to supporting us through a new venture called Tech for SickKids, which has a philanthropic component, but it also gives us a window into very disruptive innovations that I think have the promise of facilitating a 4.0. So the kind of evolution that we see and that we're trying to follow has some real implications for the roles that we each play. And I'll just close my remarks by recalling some comments that Sir David Nicholson, who's a former head of the UK's NHS, shared with the OHA Health Achieve audience a few weeks ago. And he was talking about the nature of governance in an environment that's aimed more at population health. And what he talked about is that if we want healthcare systems to function in a particular way, for example, to address care seamlessly across time, place, and clinical domain for defined populations, that we need to organize governance to support that. Otherwise, the operation of the system is going to follow the way our governance systems are organized and function. So I think there's a lot of insight in that statement, and as we all contend with the universal truths of healthcare and the promise of a population-oriented approach to deliver greater value, we all need to think about what Nicholson's comments imply for us. So we have one of the greatest systems in the world here, and I've really come to appreciate the advantages and the power of the healthcare system in Ontario and across Canada. There doesn't really seem to be anything better. I think all systems are sort of built around different trade-offs. The question isn't, are we good, but the question is really how do we address the ongoing evolution of healthcare that at least I see, and you may choose to disagree, but that I see as inevitable, because ultimately it's better for the public that pays for services, one way or another, whether it's through taxes or the choices that they make to spend out of pocketbook. And they're going to continue to demand greater value. And I think it's only through this evolution that we can really meet the pace of evolution and improvement in value that people are expecting from us.
So thank you, Mike, for that very quick trip through 100 more years of history and the sort of dynamics of healthcare. So we have the advantage in your perspective here that you've worked on both sides of the US-Canadian border and you've seen both systems. And from my perspective, I think both systems are really focused on trying to create this new linked, patient-driven system that's characteristic of the third and fourth areas that you described. But are the same strategies going to work on both sides of the border, or do we have to think about that dynamic differently given the different nature of the system?
I think it's pretty clear we will follow different paths, in part because we have made somewhat different trade-offs between the two systems. And we certainly have a different way of looking at the autonomy of healthcare institutions in the U.S. compared to Canada, where the system is built around the concept of public administration. So there's a much bigger hand for government, which has advantages and disadvantages. In the U.S., although most healthcare is delivered by not-for-profit organizations that are not that different from SickKids or UHN or the other organizations in this province, the reality is that the economics for those organizations work the same as if they were for-profit institutions. And so there are kind of rough-hewn regulations that limit what organizations can do and can't do, but the evolution has followed more the trajectory of other industries, in part because the economics are not that different than commercial transportation or lodging or other things. Here we rely more on government to bring organizations together or to transcend the boundaries to create that sort of a network. There are advantages and disadvantages to both. The biggest disadvantage that I see in the U.S. is that if there's not sort of a paying market for certain services, they don't get delivered. So there's a significant problem with unserved people. Uninsured is sort of the most obvious, but there are other populations where there's just not enough of a financial incentive to sort of go after adding value for a particular population or not. Here, because those same people vote, there may be more public pressure to create value for populations and to leave fewer people's needs unmet. And so I think in some ways there's a trade-off between freedom to make choices around who you're going to serve and how you're going to serve them, and equity that plays out differently in the US and Canada. So it will evolve here differently, but ultimately, I think you get to the same destination one way or another, because ultimately, if the public doesn't feel that they're getting enough value out of the system, they're going to vote a different way. And people's expectations around healthcare are being shaped by their experience with online shopping and dining and travel and everything else that they have come to expect to be more self-directed.
It's interesting, though, as we look at the U.S., the pace of change seems to be much faster than the pace of change we see here. And some of the initiatives which I think have drawn a lot of interest here, accountable care organizations, accountable communities, value chains, and disruptive innovations that pop up on an ongoing basis, have created a very different dynamic. What's your sense of how we can learn from that, and which of those are going to be powerful innovations for us here?
So I do think it is easier to disrupt at least at a small scale in the U.S. than here. It's probably easier to disrupt at a large scale here, in part because of the public administration. It's hard to get to the point where you're willing to flip the switch, but once you do, you can create a lot of change. And you think about the Patients First strategy as an example, kind of a province-wide approach. I lost my train of thought there for a second, but I think in the U.S., if there's a market opportunity, somebody will go after it. I mean, there's a constant effort to disrupt, and there's a great deal of freedom in creating value chains and reconfiguring the way organizations relate to each other. I actually think in this province, we have some unique advantages compared to the other provinces in Canada, where there is a much more centralized administration. I look at Alberta as an example, also a very fine healthcare system, but it's very centralized there with the health authority essentially managing the system. Here, institutions are generally, for the most part, autonomously governed. There's a lot of coordination at the LHIN level and at the level of things like Cancer Care Ontario, but there still is actually more freedom than I think organizations choose to exercise to create those value chains and to create approaches to governance that would get you to the same place.
Okay, so we do have some opportunities and advantages here, and I saw Susan Fitzpatrick here in the audience, and she and her colleagues in the LHINs across the province are really working on this idea of emphasizing a local connection, local organization, and developing sort of regional focus on what happens. But it seems to be a tough sledding to do that in this environment. What's your advice for leaders like yourself and boards in this province in terms of addressing those kinds of issues?
So I think what the LHINs are trying to do in terms of providing a more bespoke solution for local communities is very valuable. I think that the challenge is, and this is just one person's view, I think you actually sort of need two levels of looking at this. You need a way to look locally at how do you connect, for example, the healthcare and social care systems more intimately. And when you start getting into the social care system, it's very, very distributed, it's very locally governed. It's hard to centralize that in a way that's going to create the right connections to healthcare. When you look at the connections, for example, to independent physicians, that's going to be very hard to do with centralized governance. And I think we need to have the kind of approaches that the LHINs are taking to forge those connections and to think about how to plug in local providers into a continuum of care and a broader network. But that doesn't mean instead of a more central governance that actually addresses the fragmentation and the super concentration that happens with specialization. And I think the way we need to really think about it is tiered networks of service that actually have broad governance across them. And when I talk about governance, I'm not talking about just planning and budgeting, but really a way to create accountability for systems of care that span organizations, but that rely on local control for that last mile, if you will, and that use centralized governance to coordinate the actions of the local control. So, again, the pediatric services, they're not that different than the adult healthcare world, but they're a little bit of the canary in the coal mine, in part because it's so specialized that the problems around specialization and concentration are exaggerated. But if you look at an organization like SickKids, so we only get 17% of our patients from the Toronto Central LHIN. And as the LHIN begins to look at a sub-LHIN strategy, which is absolutely an appropriate way of thinking about that last mile connection. So I don't want to insinuate that that's the path. I actually think it's a very productive path. But as we think about that sub-LHIN strategy, we don't get more than 4% of our patients from any sub-LHIN region. So for us to connect a continuum of care out to the home through sub-LHINs, it means having an executive at the table of like 20 sub-LHIN region tables. It's just not practical. And so, the issue for us is how do we establish some way of interacting in a common way at that sub-LHIN level, not to eliminate it or neutralize it, but to make it easier for each of them to plug in a consistent way with organizations like ours. And when you get to a patient engagement strategy, it's even a bigger challenge. We're getting patients from indigenous reserves up in the north, from Sioux Lookout, from Timmins, from a number of small communities. And we would like to have a seamless way of relating to those patients, collecting data about what's happening in their homes and their experience with healthcare in the community, but also sharing knowledge and being able to influence the care in a way that promotes the best care at a distance. That's not going to happen through a sub-LHIN or a LHIN strategy unless there's a way to kind of look at the accountability across those boundaries in an effective way. And again, it's no different if you look at, I'd submit if you look at the care that Princess Margaret's delivering, particularly around things like bone marrow transplantation, you have the same issue. I mean, there's not that many centers doing that. Adult cardiac surgical care, same issue. Stroke care, same issue. So it's not unique to pediatrics. It just so happens we're more concentrated than others.
Yeah, so that's a good point. I mean, I think the specialization of SickKids gives you a larger challenge in terms of integrating at a local level, as you said. On the other hand, there's a variety of technologies that are going to allow us to do that and collect data and create communities and create linkages that weren't possible 10 or 15 years ago. And I think, I think about the reorganization of care that you're describing. It has to happen at different levels, doesn't it? It has to happen at a governance and leadership level, but the critical piece is the reorganization at a clinical level in terms of the connections between frontline clinicians in the community and in the hospital. And sometimes those two processes don't align. So how do we help to ease that friction so that we can create greater connection between those delivering care in specialized environments and those who are providing care on an ongoing basis in the community, both in healthcare but outside of healthcare?
Yeah, so I think that's a big part of the challenge. I mean, technology is certainly a major enabler. Sorry, I'm not sure what that was. Technology is certainly a major enabler, but technology has its own set of challenges, actually. And we're looking at a shared electronic health record between us and Ottawa that we hope ultimately will be able to connect a lot of the other pediatric healthcare providers. And that's sort of one approach, and that offers the ability to provide telemedicine support to remote communities right from the system. But there are even issues of sort of governance, and it's not governance or regulation. It's sort of the ecosystem that's created by the combination of regulations and current structure. But there's some aspects of that actually get in the way from the kinds of of tools that one would like to take advantage of. So I'll give you an example. It would be phenomenally valuable to be able to, in an ongoing way, identify patients that are shared between, us and Holland Bloorview, or us and CHIO, or us and the Children's Treatment Center in Grandview. The current regulatory environment, and I think this is for good reason, so again, this is not a criticism, it is what it is. It's something that we got to address, but the current regulatory environment and the way we think about privacy protection doesn't allow us to actually do that analysis and spit out the set of patients that we both share, because it's currently viewed as a disclosure to each other, which doesn't have permission of the patients to do. And yet, that's pretty central to thinking about how do you build a set of services that address a continuum of care and that actually could be used for planning, for service changes, and frankly, to identify individuals that specifically would benefit from a different approach. And that same dynamic has happened in the US, and the same sorts of regulations exist in the US. And so that's actually been something that's driven integration in the US. Organizations have come together and come under one governance in what have been called clinically integrated networks, even though they maintain separate licenses for their hospitals, but they've kind of come together in clinically integrated networks, in part so that they have the sort of legal cover to understand what's happening with the shared population between them, and to be able to identify individuals within that population that would benefit from a different approach to care. And I think for me, as somebody that's trying to keep our organization at the top of the children's hospital heap internationally, Ontario making this transition effectively between Healthcare 2.0 and 3.0 at least, is an existential issue for us. Because the comparison set that we measure ourselves against, Boston Children's, Children's of Philadelphia, Great Ormond Street, are all working pretty effectively now in this Healthcare 3.0 world. And the way they're measuring their impact is with the longevity of kids with heart disease, longevity of kids with cancer, their neurocognitive outcomes out 15, 20 years. If we're not configured to do things in the same way, it'd be very hard to keep those families here in Ontario. It'd be very hard to continue to advocate for the kind of philanthropy that we're so blessed to receive from a generous community here, by arguing that you're supporting the very best that healthcare offers. If we're not in that 3.0 world, I don't believe we will continue to be the best. In the 2.0 world, we're as good as it gets. And I think Ontario in general is as good as it gets. We have really fine providers, safe and effective hospitals, good doctors, good nurses. It's the transition from 2.0 to 3.0 that I worry about. There's no place in the world that's at 4.0 yet. So I'm not worried about that, although it is interesting to see how disruptors are trying to figure out how to drive things there. But there's, we do a lot of work around the world, in Asia, in the Middle East, in Africa, Europe. There's no place that I would say is at a healthcare 4.0 type of world yet. I think that's where we're going.
So there's a bit of a dilemma, though, isn't there, for large organizations like SickKids, which are highly specialized, because they've been the sort of center of the pediatric universe. But now what you're saying is we need to focus on systems that really enable patients to make the choices and to put together the kind of networks they want. So SickKids now has to think about how they can be most appealing in that environment, in that world, rather than expecting everybody's just going to show up at their door because, it is SickKids.
Absolutely. And so I would say that mental shift has been one of the hardest things internally to manage, to navigate. We have viewed ourselves as a highly specialized place that everybody should come to get the best care. And yet, we don't have the capacity to do more with our current environment, nor can we actually deliver care across the full continuum, nor should we when we're caring for a very distributed population. So I think in a healthcare 2.0 world, the hierarchy moved from, kind of within hospitals, the hierarchy between different physician specialties and between physicians and nurses, to now hierarchy between organizations, places that would view themselves at the top of the heap and would look a little bit differently at others. I think the successful leaders in this transformation have been the ones that don't try to use their position of strength to direct, but actually work to support the elevation of all the other players to the same level. And so we're really to an appropriate level for what they do. It's not going to be the same level. They're not going to do the same things, but the appropriate level for what they can do in that environment. And so, I think it actually changes the role for places like SickKids from, we have to continue to be exceptional in the highly specialized work. You can't give that up. But we also have to become exceptional at knowledge translation and doing that in a supportive and not a directive way. And, a big part of Kids Health Alliance is, we chose to not go it alone, in part so that we were forced to really have to negotiate the waters, to build a broader platform, to do it in ways that would have a greater ability to impact a broader number of stakeholders by not forcing organizations to choose, are they going to align with SickKids or CHIO? But it has meant us taking on a different mandate. And I think one of the challenges that I see, and there is this, I'm not sure what the right word is, but wariness, maybe I'll say. If you kind of talk about healthcare transformation and you talk to community stakeholders, admittedly, there's a wariness in the community about looking to the hospitals for greater leadership. And it shows up in a lot of different ways. We shouldn't put more money into the hospitals. Hospitals are expensive, all those things. But at the same time, when you think about the coordination challenge of transcending organizational boundaries, when you think about the systems that it takes to create the kind of accountabilities, to make the kinds of investment decisions in expensive capital for IT systems and other things, and when you look at where some of the key expertise is clinically to drive approaches to shared care and distribution, it happens to sit in the hospitals. And we shouldn't worry that the hospitals are going to necessarily make decisions in their own self-interest. If they do, that's the wrong approach, and they won't be successful in creating the kind of network that they need to. What they need to do, in my view, this is again just one person's view, they need to take on a broader mandate. And hospital boards need to see the mission not as their mission, their fiduciary responsibility, not as perpetuating what the hospital is about, but about making sure that the hospital has the maximum value and impact for the broad population it serves. And the only way to do that is to take greater responsibility for championing the evolution of the system. I will say, as we thought about our strategic plan, the last one versus this one, our last strategic plan also talked about the health system. It talked about leading a pediatric health system. We changed that language, and we now talk about championing the evolution of a more connected system, because I don't actually think that we can take on the mandate of leadership. We're happy to, we're asked to, we certainly wouldn't reject that, but I don't think that's the way to get there, and the way to get there is to try to get other people to see the mental model that we see and have them be willing to plug in, and in some ways be willing to share power, responsibility, governance in order to get more impact over a broader continuum of services.
So what's your advice for areas where there are hospitals that don't have that broader mental model about the evolution, and people who say, well, yes, the resources are in the hospital, but we have trouble working with the hospital because the hospital wants to own everything that happens. But really, it has to be a partnership. It has to build on the expertise and the experience across the sector. And as you know, there's great suspicion about what to do that. But it sounds like your board has taken on a broader perspective here. How do we infuse that more generally? Because I think that's not the case. We see boards in some places that are more interested in protecting current mandates than in moving into a new system. Yeah.
So I think that is. It is a challenge, and I think it's boards, it's executives that First, I think there's a lot of smart people in the province, and our governing boards and our executive teams are quite capable and generally very bright. I think there's sometimes a lack of perspective more than anything else. wary about looking across the border because we see, I would say that there's myths about both healthcare systems, and it's really interesting to kind of have the experience of trying to understand a new one and have to explain the old one. And you learn a lot about both in the process, and you actually develop a very different understanding about both than a lot of your colleagues on either side of the border. So we often are quick to reject, what's happened in the U.S. in part because of the cost of healthcare, which is a choice by the public as much as anything else, frankly. And we also reject it because of the uninsured. And both of those are fair criticisms. At the same time, if you look at the power that's happened from the network building and the integration, if you're a provider or a patient within those systems, and if you're fortunate enough to have the insurance to get you covered at Mayo or Cleveland Clinic or Kaiser Permanente or Geisinger, these are really powerful systems. And they are taking on the responsibility to figure out the connections to the social care system. Cincinnati Children's, which would be one of our peers in the US, has an extensive network with ambulatory surgery facilities, primary care, home care agencies. They have taken on the responsibility of connecting to the social care system for patients that are, for kids that are at particularly high risk. They just published a paper, I think it was either in JAMA or the New England Journal 2 weeks ago, that talked about their experience connecting with the social care system by leveraging school clinics that they help staff and promote, fire departments, other community service organizations to have a very focused approach on addressing healthcare utilization and deterioration in socioeconomically impoverished kids with asthma. And what they found was a 40% reduction in emergency department use and a 40% reduction in inpatient hospitalizations. They've taken a broader mandate. Nobody's asked them to. They're looking to try to have a bigger impact. It's the right thing to do. For them, if they're successful in doing the right things, they're going to get better philanthropy, better treatment by government. They're not going to get paid anymore necessarily. But their board has taken that on. And it's actually interesting. I was a reviewer for their quality program 2 years ago when they were just starting this work, and they rolled, they explained it to me, and I have to say, I was actually scratching my head, wondering why, and kind of challenging a little bit about could they, not that it wasn't worth doing, but could they actually have an impact? Because once you get into the social care system, it's now like lots and lots of individual contributors that all are kind of self-governed or governed by their own vehicles, and I was skeptical, but it's only been 2 years, and they published that paper, in one of the most prestigious journals in the States. So the quality of the work is very high, and they had a really impact in addressing the social determinants. And these were the biggest impact were in kids insured by Medicaid, which is the insurance program for kids that are living in poverty. It shows the ability of leveraging the quality improvement expertise, the systems, the governance structures, if organizations are willing to take on a bigger mandate. And here's the thing, you can try to be self-preserving in not going there, but somebody's going to innovate around you. Because there's an inexorable demand for more value. The public will not tolerate. I mean, they may let you negotiate the pace, but there's no way that we're not going to continue to add value in the healthcare system.
So if, just to sort of close this and then open to questions from the audience, what one or two things would you recommend for leaders in our system to really move more swiftly into this new era of healthcare and to really focus on the system components rather than the individual and organizational missions? What things will move that forward at a more rapid pace in Ontario and in Canada?
So there's one that is personal behaviors and one that's systems. So I think from the standpoint of personal behaviors, I think every board of trustee and every executive, every leader has got to be asking what can they do to help others collaborate in the way that will create a better, more effective continuum of care. So not only what can I do better, that you got to do that anyways, that's the ante for being in the role, but what can I do to help create a more effective system by enabling partners. So that's one. And that's a choice that people make. The second is that I do think we need to invest more heavily in technology, information technology, with a vision of what the systems need to accomplish in order to enable coordination, because the coordination challenge is really, really formidable. When you think about what needs to be communicated, I still have a very small clinical practice on our complex care team. When I think about the information that has to be communicated across a lot of different providers for any one of my patients, I don't know how you do that without a really integrated health record. And I'm not talking about the Connect strategy. I'm talking about a really integrated, comprehensive clinical information system.
Okay, let's see if there's a question in the audience for Mike. How do we get to healthcare?
Mike, Ross, thank you very much. So we do have time for about 2 or 3 questions, maybe. So if you have a question, you have Rebecca over there who has a mic, and myself as well. So just put up your hand, and we'll come find you. Are there any questions? Yes, the back.
Just a quick question. What I've noticed is I think they're also the insurer. So they have an incentive to better wrap their services around an individual as a way to get the insurance costs down and make the insurance program more profitable. How much do you see a way we could actually leverage OHIP to kind of mimic that experience, actually not only deliver better care and better wrap services around people, but actually help manage systems?
The simple answer is yes. I think aligning payments in different ways, structuring payments in different ways, is a big motivator. I mean, we build a strategy based on what we think we can get paid for, we're not necessarily building a strategy to make as much money as we can, but no margin, no mission. So ultimately, we configure our services in ways that address what the government's willing to pay us for and how they're willing to pay us. I will say though, and I think you're right, that the entities in the states that actually own the risk, so that are the insurance companies, have been among the most rapidly transforming. And I was talking to somebody last night at an event that was talking about Kaiser, that they've now crossed the point where across Kaiser, half the visits are virtual. They're the only place that can do that, because since they're paying the bills, they don't need a policy change around what telemedicine will be paid for or not. It's a business case for them. They just do the business case, and they can do that. But having said that, I will say that there are very, very good integrated systems in the states that don't have the insurance function. And the system I got in Philadelphia is one example. We had a children's hospital that was just like SickKids, pretty much service by service. But we also had 300 primary care pediatricians across 3 states. We had 4 ambulatory surgery facilities, each in any direction about maybe 60 to 100 kilometers away from the main hospital. We did, in those centers, we did day surgery, mental health, cross-sectional imaging, including MR, full set of physio services. We had a home care company, and we had 13 community hospital relationships that we were responsible for providing all of the pediatric services in. And this covered most of the lower half of New Jersey, southeastern Pennsylvania, and at various points in time into Delaware. And it was one electronic health record, one management team, one medical staff, and there were great advantages. If you were short medical staff in one location and I had responsibility for this network, I could just move overnight and have them move. When we pushed out a new standard around the primary care management of ear infections, as an example, 300 people got that overnight. And we could track their compliance with that standard through the electronic health record the next day. and we could communicate to families about why we made that change through a patient portal to, the 50% of all of our patients that we provided all the care for. The other 50% got some of their care from us and some from others. So, and we had no insurance function. We contracted with probably 15 different insurance plans, and we did it because it added value. It made us a more attractive provider, a better place to work. So there's lots of reasons to do it, and the path has followed a similar path even in those places that don't have an insurance function.
Thank you very much for this morning. It was a wonderful talk. Our next breakfast with the Chiefs will be with Rachel Brown from Vice Media and Andre Picard from the Global Mail as we discuss the relationship between healthcare and the media. Thank you and have a good morning.